This talk will be an overview of medications used to treat diabetes mellitus, type 1 and type 2. To understand the various pharmacotherapies that are used in diabetes management, it's important to understand first how the pancreas works in normal homeostatic conditions, so understanding the activity of the various endocrine cells in the pancreas. There are plenty, but today we'll be speaking mainly about alpha and beta cells in the pancreatic islets. They secrete products called insulin and glucagon. Those are integral to general glucose homeostasis and also to then the management of diabetes. There are two subtypes of diabetes mellitus. We will understand the difference between those two etiologies. They are very different disorders. So there is generally a treatment that goes along with each one. You can see some crossover, but generally we have medications that treat type 1 and ones we consider more the management of type 2. Knowing those drugs, primarily being able to recognize those drugs, know what class they're in, and know what their general mechanism of action is really important in decision making. That being said, this is pancreatic pharmacotherapy. When there is an abnormality with endocrine function of the pancreas, it is going to involve pancreatic islet cells. Again, alpha and beta cells. The pancreas is both an exocrine and endocrine gland. Its exocrine products are things that are made that travel through a duct system and are released into the external environment, like pancreatic juices that travel through the pancreatic duct and are released into the duodenum. Whereas endocrine products are secreted by cells into the bloodstream as hormones. So the endocrine system involves hormones, and those hormones in some way work to maintain homeostasis. The main endocrine function we'll be talking about today is the homeostasis of glucose metabolism, how we utilize our energy that is stored and ingested. As I mentioned on the previous slide, the exocrine cells of any system are releasing products into a duct system. That's what you see here. And those cells are organized into an epithelial layer that from the outside resembles something like a bunch of grapes. And together that individual grape made up of individual or exocrine cells are called acinar cells. And so they are organized into acini, and those acini or acinar cells, they secrete hormone into a duct. So that's what you see here. Those are a collection of exocrine acinar cells. They would be making exocrine pancreatic products like pancreatic juices that would travel through the pancreatic duct. So that lets you know those are not the cells that we're talking about. Instead, in the endocrine functionality of the pancreas, we have cells that lie within an anatomical unit called the islet of Langerhans. And the islet of Langerhans contains two specific types of cells that are very important to recognize in diabetes. The first one, here in light blue that I covered up a little bit with my circle of islet of Langerhans, is the beta cell. And beta cells are responsible for the creation and secretion of insulin. So those are the ones we primarily think of in the treatment of diabetes, but not the only ones that are important. In dark blue, we have the alpha cells. Alpha cells make the opposite or the countering hormone to insulin, and alpha cells secrete glucagon. Insulin and glucagon work in these opposing ways, and they are essentially antagonistic to one another. This is part of a physiologic feedback loop whereby the only thing the body is worried about monitoring is levels of glucose in the bloodstream. There's no brain involvement, there's no hypothalamic or pituitary axis. We have beta cells monitoring glucose levels in the bloodstream. And when those glucose levels start to drop, we get the signal to alpha cells to turn on the production of glucagon. And glucagon raises blood glucose. When blood glucose gets too high, we then have the signaling to beta cells to release insulin. And insulin decreases blood glucose levels. So these two opposing hormones work to maintain glycemia, so the regulation of blood glucose, by being released in response to specific levels of glucose in the bloodstream. So, one of the primary goals in the management of diabetes mellitus is going to be altering activity or substituting activity for the beta cells. In each typology of diabetes mellitus, we are going to have abnormalities in insulin secretion, which means there's either going to be an underperforming of beta cells, an overwhelming of beta cells so that they cannot meet the demands of the tissue, or a complete destruction of the beta cells. Beta cells, in their creation of insulin, are integral to glycemia control. In the most simplistic sense, in individuals without diabetes, the pancreas makes insulin from beta cells when it is necessary, when blood sugar gets too high, because insulin helps tissues utilize glucose so that it's not kind of hanging around in the bloodstream. So insulin is really important for that. In diabetes mellitus, and mellitus actually comes from a word that means sweet, which tells you something a little bit about the disease. But in diabetes mellitus, there's insufficient production of insulin from the beta cells, such that glycemia control is altered. Those reasons for insulin insufficiency are different depending on which diabetes we're speaking about, but generally it is a problem of insulin insufficiency. In diabetes mellitus, again, for whatever etiology or cause, we see abnormalities with glycemia or blood glucose regulation. High blood glucose will be a signal to the beta cells in the pancreas to make insulin, and insulin helps tissues utilize glucose. So glucose in the bloodstream, glycemia, is driven down by virtue of glucose utilization. So insulin drives down blood sugar until we reach normal homeostasis. In cases when blood glucose is low, alpha cells of the pancreas make glucagon, and glucagon releases stored glucose. So glucose is stored as glycogen in the liver, in the muscles, and essentially we break that down into freely available glucose so that glucose can enter the bloodstream, and we bring up levels of blood glucose. So this is the way the feedback system would work normally. However, this is what is altered in diabetes mellitus. The other steps of your feeding still maintain the same. The stomach breaks things, macromolecular structures down into things that are usable, that are able to be absorbed. So the stomach changes food eventually into glucose through digestion. Glucose goes into the bloodstream. That's working just fine. Where we have the issue then is with the pancreatic secretion of insulin. If we do not have sufficient secretion of insulin, glucose in the blood cannot be driven down. We cannot do that. That means glucose without insulin will stay in the bloodstream, and high levels of blood glucose have a lot of negative side effects associated with them. So it is important that insulin be secreted to drive down blood sugar. If we do not have the ability to make insulin or make sufficient insulin, then we have to find a way to substitute insulin or promote utilization of insulin or other stored products. And that's where the pharmacotherapeutics come in. As mentioned, there are two different types of diabetes mellitus, and we'll go over them now. The first is type 1 or insulin-dependent diabetes mellitus. And in this case, the main lesion, which is a pathologic term for where the damage is, so the main damage is to insulin-producing cells, so the beta cells of the pancreas. We don't really know what starts this, but most theories that I've read recently implicate a virus that caused antibody creation, and those antibodies acted as autoantibodies attaching to the beta cells. And you might remember that if something is covered, that's an antibody, if you can't tell. If something is covered in antibody, that means that it is cleared for destruction. So here's a macrophage. It would be attracted to these beta cells with antibody on them, and they would eat away at those beta cells, thus destroying them. And this generally presents early in life, which is why you will sometimes use, or you shouldn't use it, but might hear the term juvenile diabetes, because it is something that is present, or at least makes its first presentation in childhood or early teenage years. And this is a disease where there is destruction of the beta cells. And if there's no beta cells, we're not going to have insulin creation, which is where we get this term, which is much better than juvenile diabetes, but insulin-dependent diabetes mellitus, also called type 1 diabetes mellitus, IDDM. So that's telling you that they are dependent upon an exogenous source of insulin. Exogenous means it's created outside of the body. They need to supplement insulin because they cannot make their own. The way you can visualize this, if we look at the way glucose is trafficked throughout the body, glucose is one of our primary energy sources. Our brain uses it readily, and other cells in the body, our muscles, our tissues, they love glucose. It's a very preferential form of energy. However, in a lot of fasting states, our tissues don't usually use a ton of glucose because we're saving it for the central nervous system. So that means physiologically, the body generally does not have cells that at resting potential are able to take in glucose. The two types of cells that are important right now that can take up glucose at resting potential are the beta cells in the pancreas, which need to take up glucose because they monitor glucose levels in the blood, and they can have the intake of glucose without any other thing needing to accompany the glucose. The other tissue that's like that, as I alluded to earlier, are neurons and other cells of the central nervous system. At their resting potential, glucose can transit into those cells so that they can be used immediately without any lag time, that glucose for energy. However, all the other body cells that can use glucose as a form of energy cannot take in glucose at their resting potential. So here's a pretty simple drawing of a fat or muscle cell that is at its resting potential. It's not doing anything, it is just existing. At rest, the transporters that could bring in glucose are closed. These are called the GLUT4 transporters. This is the way glucose would enter this fat or muscle cell. And the way I like to think of glucose, so here it is up there, It's like that annoying neighbor that is constantly knocking on your door and they want to borrow your gardening stuff, or they want to hang out. They want to invite you over to their stupid backyard, and you are tired of them coming over and knocking on your door, and you do not want to let them in anymore because you've discovered boundaries. That's glucose, always trying to disrupt those boundaries. And fat and muscle cells have great boundaries, and they do not let glucose in at rest. However, if glucose is accompanied by insulin here in this triangle, then it's a different story. So insulin binds to its own insulin receptors, these fun dimerized receptors. And when insulin has bound to its receptor in the tissue, that stimulates the GLUT4 transporters to turn on so that we can start trafficking glucose into the cell so it's utilized and not hanging out in the bloodstream. And it also activates other glucose transporters to undergo their conformational or shape change to open up and allow glucose transport in. So insulin is like the really great neighbor with the really good stuff. Like they've got a hot tub and jet skis and $5 for you. So even if glucose, like your annoying neighbor, is knocking on your door, if they're with your jet ski neighbor, you're going to let glucose in. So it's like insulin has a secret knock. When you hear it, you're like, yes, that's my boy. I'm going to let him in. And it's fine if glucose comes because insulin makes it worth it. So we need insulin to first bind to its receptors to allow glucose transporters to become active. Once they are active, glucose comes into the cell. So we can augment this process in various ways pharmacologically, but this is the general process that we need to restore. And this is why insulin is so important in the regulation of blood glucose. It moves glucose. Insulin allows glucose entry. And when somebody is dependent on an exogenous source of insulin, it means that we cannot just wait for the body to regulate itself because it is not secreting insulin, so it needs to then be monitored. The individual, through various ways, is asked to monitor their blood glucose throughout the day, and depending upon whether or not they've just eaten or if they had a high carbohydrate meal or what their levels of glucose are like, they will be administered a specific type of insulin, an exogenous insulin, to help drive their blood sugar down. So it's this constant monitoring of glycemia in the place of the pancreas. So essentially, pharmacotherapeutically, we are giving that person pancreatic function. Another measure that I want to mention very quickly is the A1C level, which is different than a daily blood sugar test where you're monitoring highs and lows throughout the day and getting a lot of data about specific meals and your physiologic response and then drug requirements. The A1C test is something that takes into account an average of blood sugar levels around the past 3 months. So it is capturing a long-term picture and does not capture then the individual highs and lows that you would see throughout the day with normal and abnormal insulin production, which occur as a result of feeding. So hemoglobin AIC, or glycated hemoglobin, is a measure of glucose that is bound to hemoglobin. Many monosaccharides, so glucose included, spontaneously bind to hemoglobin when it is in the bloodstream. So an A1C level tells you how much glucose is available at that time and has bound spontaneously to hemoglobin. Again, this is something that looks at average levels and can be used to set long-term goals. There's normal levels for individuals without diabetes, and then there's diabetes levels. Like for most people who are undergoing treatment, they might have a target of an HbA1c level of 7% or lower. So it lets you know if you are meeting your targets, if anything needs to be off, but it is not a minute by minute calculation. It is more so a long-term measure. Not surprisingly, because type 1 diabetes is insulin dependent, the treatment of choice is insulin. They lack insulin, they cannot make it, so therefore we need to supplement it. Insulin, remember, physiologically, it binds to its insulin receptors, and those insulin receptors allow glucose transporters to open and glucose to go inside of the cell, thereby lowering blood glucose. When that happens, that's going to lower blood sugar, and that is called hypoglycemia. So that means when you give an insulin, it's very common sense physiologically that the most common side effect is low blood sugar, hypoglycemia. That is why a fine-tuning of the system, there are many different delivery methods that are available now. There are all-day sampling systems that work through a patch that goes onto your arm that works with Apple Health on your iPhone to monitor your glucose levels throughout the day and signal to an insulin pump to give you an exact amount of insulin that you need to get to your desired range. So it makes sense that that is the most common side effect, is low blood sugar. That's what insulin does to begin with. So we've got so far our mechanism of action. The mechanism of action of exogenous insulin is normally what insulin does in the body. It works to drive down blood sugar by promoting glucose uptake by cells. So that's our mechanism of action. Now, let's look at route of administration. If you've ever heard of somebody taking an insulin pill, chewing an insulin capsule, they probably bought something that didn't work. So you cannot take specific types of peptide hormones by mouth because they are not stable in stomach acid. Insulin is an example of this. Insulin must be given by injection because it would be destroyed by stomach acid immediately otherwise. The preferred route of administration, especially when you're dealing with chronic control of type 1 diabetes, is subcutaneous injection. We'll look at a picture of this in just a second. Subcutaneous into the adipose tissue, that's a really great way to prolong the activity of the insulin in the body, just because that's a nice place where it is not as soluble as the rest of the body, but also has enough blood flow to allow quick activity. So all of these are going to be given by injection, no oral. They shouldn't enter the GI tract in any way. When you're giving an insulin, most things made by your body have really quick half-lives. Some of them have longer, but most things, they're really quick. So when you give insulin IV, which is 100% bioavailable type of way to give it, it only has a 10-minute half-life. So giving it in a different route, like subcutaneous into the adipose layer, that will extend the length of activity. All right, now I'm going to throw a word at you really quickly, and it is a fun word, and it is prandial. It sounds great when you say it. Prandial. That's a P. Prandial means having relation to mealtime. So that means feeding, eating. So we will divide insulin by its length of activity and really its onset. Is it going to work right away for a short amount of time? Is it going to be more intermediate, or is it a long-acting type of insulin? We have different formulations, rapid, intermediate, and prolonged activity. And you will hear the term prandial or postprandial control and use of insulin. So prandial means that it is associated with a meal. Are we going to eat right away? Right? Are we preparing to eat? Because when we first enter that cephalic phase of digestion, when we're starting to think about food, smell food, chew food, not only does that stage turn on different processes in the body that increase stomach acid production, it also turns on some of the beta cells in the pancreas. So we start insulin secretion right away. So prandial use of the drug means mealtime or eating related. Postprandial then means after eating, after a meal regulation of blood sugar. So not specifically associated with a donut or a bowl of oatmeal. It is something that is more long-term, not eating related. That being said, there are a lot of different options that are available for management. We can have management that includes administration of rapid onset medications that would be given before a meal, 10 to 15 minutes before. So pre-prandial or prandial administration, things like Aspart, Lispro, crystalline zinc insulin, insulin zinc. And you might see some of these names in different places, because depending upon which solution it's in, what the pH is of that solution, what it's suspended in, and where it's injected, the same substance can have up to 50% variability in the insulin and then glycemic response in that individual. So we can really alter the pharmacokinetics really just by putting different things in with it and then giving it different ways. So a rapid onset would be used before a meal to cover the normal insulin spike that would occur physiologically with a meal. Whereas intermediate onsets would not be used so much for prandial administration. It's used for more intermediate or not even a full day, but maybe up to a full day control of blood sugar with maybe a little bit of use of an immediate onset. And then there's really prolonged action insulins that work long-term to establish a set blood sugar. So I just plop that in there for you from a nice pharmacology textbook that I am obsessed with. But what you're looking at here in this picture is what use of these various types of insulin might look like. So in red, you have insulin analogs, which means that they are things that look just like and act just like insulin, which remember physiologically is released right before you start eating, spikes when you eat, and then stays really high for a couple of minutes and then goes down. It spikes with feeding. So an insulin analog looks just like insulin and acts just like insulin. So those are your short-acting medications. What you see here, B is for breakfast, L is for lunch, S is for supper, and HS is for bedtime, it says, but whatever. All right, so when you see an arrow, that's an injection. So if you're using an immediate onset drug, that would be a prandial use. You're giving an injection of an immediate acting insulin analog associated with meals. And then in green, you have a medication. Then in green, you have the name of one of our long-acting medications. You actually see it down here, prolonged action, like galargine or detamir. So this in green would be the underlying long-term, long-acting or prolonged action insulin that is given at a steady level, maybe in 1 or 2 injections throughout the day, depending on the formulation, that would control basal or baseline levels of insulin. And then we would require the use of an immediate acting insulin analog to handle the feeding or meal-related glycemia spikes. Panel B shows a similar treatment, but a little bit more conservative, where injection of NPH insulin twice daily covers the basal glycemia needs for that individual, and then using a short-acting insulin analog or regular insulin covers the prandial or meal-related. The final panel is showing you what insulin pump delivery of a short-acting insulin would look like. In this case, the pump delivers a large dose or a bolus dose of that short-acting insulin associated with each mealtime. So breakfast, lunch, supper, there's a large dose that's given through the pump of that short-acting insulin. And then later on at bedtime, there is a basal level of infusion so that we have concurrent mealtime that's covered with the same medication, and then basal level that's covered. And it's this constant feedback working in a really similar way that the pancreas does physiologically. So an insulin pump is a great technology. They've made a ton of strides, and it's a great way to keep things under control without using many different types of insulin and lots of different injections. So this is what an insulin pump looks like. It looks like a pager, which 911, 143, love you. Those are what we used to use pagers for, but now this is an insulin pump. So there are manual ones. There are now ones that communicate with a patch that goes on the body, and throughout the day, that patch takes microscopic samples of blood and sends that information to the pump through an app on your phone. There's an app for that. And this system integrates the release of insulin, which is directly informed by these blood samples that are taken throughout the day. That app also sends you a reminder, sends you a notification if your blood sugar gets to a really high or low level. It can also be set up to send that notification to a physician, or if it's somebody who set this app up for their child, they can also get notifications if their child's glycemia is off. So it's a really cool system. They call it sometimes the synthetic pancreas. But essentially, this is the pump. The pump is associated with tubing. There is a needle at the end of the tubing, which is retracted once there's an insertion, and just a flexible catheter lies underneath the skin to deliver insulin as necessary throughout the day, dependent upon meal times and levels of glucose in the blood. So that catheter goes to that subcutaneous tissue where we have subcutaneous adipose or fat. Fat cells are a great reservoir for drug. It allows drug to stay in that area for a little bit longer than it would physiologically, so that it can absorb in a nice way and we can prolong activity a little bit. So this is going to get around the injection of insulin into the body using a standard syringe. So insulin pumps, you can use any type of insulin with them, but like we saw in the slide previously, using a short-acting insulin is a great way to get coverage for basal levels and for prandial or mealtime levels. Okay, so that was our type 1 diabetes, and we went over one medication in general for our first-line treatment, and it was insulin because it is insulin-dependent diabetes mellitus. For type 2, we're going to see a whole family of medications that are used to control blood sugar in other ways. That doesn't mean you won't see some cross coverage. So type 2 drugs being used for type 1, and then sometimes insulin used in type 2. There's all kinds of things you can see in the world. But for now, know that type 1, the treatment of choice is insulin. Type 2, we've got a couple of different choices. So type 2 is not insulin dependent. These individuals have functioning beta cells, but depending upon what the pathology is, either the amount of insulin produced is insufficient, or the tissues have become insensitive to insulin. So insulin insensitivity is something that is common, and it occurs when tissues are used to getting an insulin message that there's lots of glucose in the bloodstream, and the body decides to stop attending to that. That is a cornerstone of metabolic syndrome. So in type 2 diabetes, which I am so personally victimized by this picture of a chocolate cake and a pancreas, but essentially this is showing that cake is involved, like in my life, but generally it is food, diet, lifestyle mediated. The pancreas can only produce so much insulin. So there are cases when the body literally outgrows the pancreas. We cannot make any more insulin to cover the needs of the body. We also have that insulin insensitivity. So tissues stop responding to insulin. So either there is an inadequate response to insulin or there is inadequate production of insulin. So that's our type 2 diabetes. They have intact beta cells, which means we don't have to supplement insulin. We can, though, encourage cells to secrete insulin and then other cells to take up that insulin so it's not in the bloodstream. So just like we saw the term juvenile diabetes in type 1, adult onset diabetes is a terminology that's used with type 2 sometimes, but it is more common to see it in younger and younger individuals, so it's not strictly a disease of adulthood. So that's a term we'd like to move away from. And it's common with obesity, which is just BMI mediated. So BMI is greater than, 30, I think, is type 2 diabetes predictor. And again, this is something that is either tissue responsiveness or outgrowing the pancreas. Medications work really well. However, because this is really driven in a large part by diet and lifestyle, and if the body has outgrown the pancreas, encouraging lifestyle modifications to get body weight within limits where the beta cells can meet the demands of that tissue is so important. And truly, none of the medications are as efficacious as diet and exercise in controlling the body's response to insulin. As I mentioned, that sometimes the body outgrows the function of the pancreas. A key time in life that this happens is during pregnancy. So gestational diabetes is its own type of diabetes mellitus, whereby the female body, upon harboring a fetus, outgrows the amount of insulin that is produced. So the blood sugar is high in these individuals. The fetus shares a blood supply with the mother, which means that generally the baby fetus can put on weight. There used to be weight recommendations with this, or they would make a judgment where at birth, if the fetus was 10 pounds or more, they assumed that there was gestational diabetes. Now that pregnancies are going on longer, babies weigh more at birth. So that's not a good rule of thumb. What is better is to monitor and test glucose response, or glucose tolerance, we call it. A glucose tolerance test is how well the body makes insulin to respond to glucose changes, to individuals receiving prenatal care. And this is a key example of the body outgrowing the pancreas's functionality. Because these medications work so well, we will also see here that one of the main side effects is hypoglycemia, low blood sugar. So we want to find this happy medium in between blood sugar spiking and seeing high blood sugar levels, and then avoiding low blood sugar levels. So finding this happy medium. So again, relying on medications only is predisposing that person to experiencing the effects of hypoglycemia. So I get hangry, your head hurts, you shake, you sweat, you're tired, you're weak, you're hungry. So we want to avoid that. And it is what the drugs cause. They work really, really well. So we want to find the correct dose and alter lifestyle or offer lifestyle modifications as necessary. And as I was mentioning, that's really the goal of treatment, finding this happy medium in between high glucose and low blood glucose. All right, so now we're going to get into the quick and dirty about our type 2 medications. So these fall into a variety of different classes, and the first class we'll talk about are called the alpha glucosidase inhibitors. These are also called starch blockers. They are called that because they slow the digestion of carbohydrates. You might know that carbohydrates spike blood sugar. They spike glycemia. So when we have that spike, the body will naturally respond by releasing a high amount of insulin. If the tissues already are making insufficient insulin, that is going to lead to pathology, to side effects, to damage. So using alpha-glucosidase inhibitors slows that breakdown of carbohydrates and limits the stress on the body, making homeostasis easier to achieve. So the mechanism of action of this class of medication, alpha-glycoside inhibitors, inhibits an enzyme that is in the border of the small intestines, and this enzyme generally converts sucrose into fructose and glucose so that the glucose can be liberated into the bloodstream and we can utilize these substances. If we inhibit the activity of this enzyme, we'll slow down the creation of glucose. So that's why they're called starch blockers. We're blocking this effect by just slowing down the digestion of starches. So it increases the time for carbohydrate absorption, and peak glucose levels go down after mealtime. It doesn't help any other time. If you are not eating carbohydrates or meals in general, if it's nighttime, for example, and you haven't eaten since 6 p.m., these medications aren't going to do anything. So these are really associated with eating. These can be used in combination with lifestyle modifications, with other medications used to treat type 2 diabetes, especially in patients who are not meeting their blood sugar targets or A1C targets. If these are mixed with insulin, the hypoglycemia is really pronounced. And that makes sense because we are really suppressing glucose levels into the bloodstream. The most common side effects are not that bad: fullness, pain, diarrhea, and I didn't put flatulence on there, but that's pretty high on the list as well. So those are your alpha-glycoside inhibitors or starch blockers. Our next class of medications, Biguanides or Biguanides. Say it however you want, just say it with confidence. So this class of medication has a target not in the intestines, but at the liver. And it inhibits the liver from releasing stored glucose that was stored before as glycogen when it's not needed. So we're inhibiting secretion. All right, so you might recognize the name of the only Biguanide that is still on the market, metformin. Metformin was one of the first medications that was created to treat type 2 diabetes, and it remains the top choice for diabetes type 2 treatment. Again, its main site of action is the liver, and its mechanism of action is preventing enzymatic breakdown of stored glycogen into glucose. It also has moderate effects in peripheral tissues to promote uptake of glucose by them, although that's not very well understood mechanistically. So we would say generally metformin is associated with decreased glucose output by the liver. The other medications that were in this class have been taken off of the market, and the reason why is their ability to cause lactic acidosis, so the development of lactic acid because of shifting to anaerobic pathways. This is more common in patients with pre-existing renal failure, so it's important that renal function be measured. And renal function is important with metformin in general because when it's taken by mouth, it's taken as a tablet, generally once per day. Peak plasma levels take about 2 to 4 hours, depending on what's in the stomach, to get there. And then it's excreted completely unchanged. So it doesn't bind to plasma proteins, and it is not modified by the liver in any way. It's just peed out unchanged. So if you don't have really good working kidneys, it will build up in the system and then cause side effects. So it is rare to see this with metformin, but it's an important side effect. Even though it's rare, the other ones were all taken off of the market because of lactic acidosis. So it is something to be on the lookout for and monitor in those patients. There is also a large role of the use of metformin in prevention in diabetes. So people with pre-diabetic states, they slow their progression to diabetes when they're given this medication. Metformin can be used as a monotherapy on its own. It can be used in combination with other medications. It's really potent with diet and exercise, which are also therapeutics, and African American populations respond better to metformin than Caucasian populations do. It's also safe in gestational diabetes. It's used in polycystic ovarian syndrome to reverse weight gain, and it's also been shown to not induce weight gain in patients and actually favor weight loss. So its effectiveness as a monotherapy, its activity in lowering output of glucose from the liver makes it a great treatment choice and one of the top preferred medications still today. All right, the final class of medications I will cover today are just our incretin analogs. So incretin are hormones that control the release of insulin, and two examples of those hormones are GLP and GIP. So these are also secretologs, meaning that they drive secretion of something. So they drive secretion of whatever product it is we are looking for. In these cases, it is insulin. So GLP, when released, stimulates insulin secretion. So we can alter activity of these incretin hormones like GLP-1 by messing with their receptors, with their breakdown, or with their pathways. So what we're looking at here, this is a beta cell, and normally when you eat, that high level of glucose is sensed by cells in the small intestine called L cells, and those L cells make this incretin hormone, GLP-1. And when GLP-1 is around, it drives secretion of insulin. So that's what GLP-1 does. So one class of medications, like our Januvia, Sitapliptins, our leptin drugs, those are called DPP-4 inhibiting agents. They inhibit the enzyme that breaks down GLP-1. The longer GLP-1 is in the circulation, the more insulin is secreted. So we have better control of glycemia. So we have DPP-4 inhibiting drugs like our gliptins. We also have direct GLP-1 agonists, and those include medications like liraglutide and exenatide. Those tides, those bind directly to GLP receptors, which are located primarily in the intestines to drive release of GLP-1. More GLP-1 equals more insulin. The fun fact I'll leave you with today is not only do we find receptors for GLP-1 in the intestines, we also find them up in the brain, specifically in areas that control our feeding, our hunger, and what type of food we want to eat, whether or not we're eating for enjoyment, which is called hedonic feeding, or eating to meet a caloric goal, which is called homeostatic feeding. When GLP-1 is released, not only do we get secretion of insulin, we also modify the activity of that pathway in the brain. So when you give patients GLP-1 agonists like liraglutide or exenatide or Exendin 4, those patients lose weight. And when you ask them what they're doing, they're like, I don't know, not much. Did I exercise more? Nope. Did I eat a little bit differently? Yeah, you know what? Now that I think about it, I haven't been eating as many sweets. They just don't taste as good to me. I don't really crave sweets anymore. So it actually does this thing that I wrote a whole paper about if you'd like to Google it. It shifts feeding from hedonic to homeostatic. So they're a really great class of medications. We're seeing even people with type 2 being put on these as well in addition to their type 1. And type 2 patients receiving this in addition also to their type 2 medications because it has such great outcomes, and losing body weight is such an important therapeutic in the control of diabetes in general. All right, now that I've made this slide nice and messy, that means it's time for me to stop. So I hope you learned something and I hope you stay smart. Thanks, everyone. Next, sulfonylureas. So these medications are also sometimes called secretologues, and a secretologue substance is something that promotes secretion of something else. So this class of medications promotes cells in the pancreas to secrete insulin. Remember, in type 2, there are functional beta cells, so they are there and they do make insulin, but maybe they need a little bit of a push. Maybe they need some encouragement. Sulfonylureas, they can provide that encouragement. Some examples of medications in this class are glimepiride, glipizide, glybride. There are many others coming onto the market that exist on the market. Those are some examples of some popular ones. And because they are secretion-enhancing medications, they work on the pancreatic beta cells primarily by blocking potassium channels that would let potassium leave, and potassium's a positive ion, so if you lose positive ions, that cell's going to turn off, right? It's going to become more negative. So instead, it promotes depolarization of these cells, having them reach a charge at which they perform their action. By allowing calcium channels to stay open, calcium is a positive ion. The more positive ions we have inside of a cell, the greater its charge and the greater its likelihood it will engage in an activity. So the activity that is desired of beta cells is the release of insulin. So really, this just drives action potentials in beta cells. So it drives secretion of insulin. So we get decreased potassium leaving the cell and increased calcium coming in, greater charge, greater activity, greater exocytosis, and secretion then of insulin. Most common side effect, hypoglycemia. Their job is to lower the blood sugar by inducing insulin release, and they do that very well. I love this simplistic picture and the simplistic description. Thiazolidinediones, TZDs, are a class of medications that help body cells use insulin better. So they are going to alter the charge of cells at rest so that they are more likely to take up insulin, which they normally would not do at their resting potential without insulin. Two examples of medications in this class of TZDs are rosiglitazone, pioglitazone. So these medications, they promote uptake of glucose by tissues that would use glucose as energy, but normally wouldn't take up glucose at their resting potential. They agonize a receptor type called the PPAR gamma receptor. And that receptor, when agonized, produces proteins involved in glucose and lipid metabolism. They alter the permeability of that cell to glucose. They encourage uptake. And when we have glucose in cells, it's not in the bloodstream. So that means it lowers blood sugar. So it just encourages cells to take in the glucose, take in that annoying neighbor that they would normally turn away. A side effect that is in bold because it's important is that it does increase the risk of MI. So it is important to take into account people's cardiovascular history, their family history, and to check in with them regularly about their health.